Our topic today, again, is substance use disorder assessment and screening, and I want to give credit where it's due. These slides were created by Dr. Lindsay and Dr. Bhatt of UNM's ASAP clinic. So our objectives today are first to appreciate the importance of screening for substance use disorders and co-occurring psychiatric illnesses, then to describe the recommended models for screening and assessment, and lastly, to review the common screening tools for use in a primary care and a specialty setting. This is a really info-dense presentation, so please be sure when you have questions or there's anything that you'd like me to elaborate on, please drop those into the chat and I'll be really happy to return to them at the end. So looking at the epidemiological portrait of substance use disorders here in the US, this information actually comes from the SAMHSA survey in 2013. SAMHSA always has great data, but they take a long time to come out with it. So this is the most recent that we have of this big picture info. And what it showed was that a little more than half of Americans over age 12 reported being current drinkers of alcohol. And then a little over 6% age 12 plus reported heavy drinking, whereas a little under 10% over 12 reported current illicit drug use. And marijuana was the most commonly used illicit drug. What I can say is, even though this is almost a decade old, what we do know from the more sort of piecemeal research in these areas more recently is that unfortunately not too much has changed in a positive direction, particularly over COVID. As we probably all know, that exacerbated a lot of existing vulnerabilities to substance use disorders. Similarly, on the same topic rather, just a little under 9% of people need treatment for substance use disorders in so much as that they meet criteria. And out of that population, so that's a little over 23 million, only 2.5 million, so just a little over 10%, actually receive specialty treatment. So that's a very small portion who are receiving the treatment that they need. And unfortunately, this number in particular has just barely budged over the years. It seems to always hover right around 11%, no matter how many ingenious methods we use to try to increase accessibility. So just a little over 1% of US adults seek specialty addiction treatment annually. There are so many factors that go into that. Some of the big ones, most of these we've talked about on this echo before, are of course stigma. It's not something that people are really excited to seek treatment for usually. Cost is a hugely prohibitive issue, particularly in reference to what people's insurance will cover. Of course, lack of interest, and then an issue we here on this echo are especially familiar with: lack of availability. So in rural states in general, and then particularly in frontier communities within rural states, and I know a lot of our providers here are from those communities, we know that behavioral health services are overextended at the best of time, and behavioral health care for substance use disorders in particular tends to be chronically understaffed. On the other hand, in terms of where people are likely to be able to come in and feel comfortable and sort of get identified at an early juncture, primary care offers a really beautiful opportunity to kind of catch people when they're participating in routine medical care. A little more than 80% of adults and more than 90% of children do see a healthcare professional on a somewhat regular basis. More than half of those office visits, a billion office visits, are in primary care, and then there's also quite a lot in emergency department visits. So this is a place where a lot more people can get caught at an early juncture and identified as to whether they might need help and be passed along to a specialty clinic. And something I want to note, because it's come off so often in this echo, is we've seen a lot of providers who I think give such a beautiful example of the no wrong door approach, because they might not have previously been involved in substance use disorder treatment, but they've recognized in their primary care settings that it's such an important issue, and that a lot of patients are much more comfortable with them than they would be going straight to a specialty clinic. So I think we have a lot of participants here who really illustrate the use of primary care as that first juncture of identification and treatment. So again, it's such an important opportunity. One of the biggest takeaways that we want to project here today is just how important it is for those of you who are in primary care adjacent settings to understand the power that you have, especially through screening, to identify people who might be able to benefit from more specialty treatment. So we'll look now at how we make that happen. So why is screening and assessment necessary? This helps us at the earliest juncture as providers understand not just what patients' needs are, but very importantly, to match them to the correct level of services. I think a lot of people who don't know too much about this tend to think that the more services, the better, and that's actually not true. So we'll look shortly at how we can identify where a person is in the continuum of symptoms and match that to a continuum of care that's appropriate for them. And then a secondary function of screening and assessment that a lot of people don't recognize, but is actually very helpful, is allowing us to track symptoms over time. And that in turn allows us to adjust the treatment plan as needed if we recognize that a patient's trajectory is not moving in the direction that we'd like. That is very much the best standard for treatment. And it's unfortunately something that can often get overlooked if it's a really busy organization or provider. So I'll start with how we sort of used to approach substance use disorder and the models of care there. One of the oldest is the complications driven treatment, and that's really where patients are only getting to interact with medical professionals during really acute episodes related to their use. So there's really no treatment that's tied to diagnosis in particular. It's about symptoms getting bad enough that they present perhaps at the emergency department with delirium tremens. That's treated. They're then released with little to no follow up, and, as we can very predictably foresee, they're going to be back pretty soon with the same or new complications. So this is where we used to be. A more recent generation of treatment, though the one that we're trying to move away from, is the diagnosis and program-driven treatment. So it's a big step forward from the complications-driven treatment in that this was anchored in a diagnosis, and that's a really important step to make sure it's effective treatment, and that there is primary program and aftercare services. Again, relapse is what generally triggers a repeat of the program rather than having a sort of long tail of aftercare that helps to sort of monitor the patient and anticipate if a relapse is likely. So again, really huge improvement over complications-driven treatment, but still doesn't do a lot to take the patient's perspective into account. And what we know more recently from research is that that's one of the most important determining factors in outcomes. So that leads us to where we aim to go these days, which is the client-directed and outcome-informed treatment. I want to emphasize the outcome-informed part because that's a little less intuitive. That's where the screening and assessment comes in, because what we want to do is not just at the beginning of treatment to determine how we're going to approach treatment, but also all along the way to make sure treatment's working. We want to check in using standardized instruments to see, is treatment going the way we expect it to? How do we need to modify it if not? On the client-directed side, this is a little more self-explanatory. The idea is that we really want to make sure that we're engaging the patient as the primary stakeholder in the process to identify what problems and priorities are at the top of their list. Engage them and their knowledge as the expert of their own life and how to make a plan that addresses a biopsychosocial approach to treatment, and then monitoring that progress again through screening and assessment. One of the instruments it mentions here that we won't go over today, but I think is important to mention, is the session rating scale. So that's a proximal outcome rating. And that's actually one that you could fill out potentially in every session. It's just 4 questions on a Likert scale that has to do with the therapeutic relationship and the patient's perception of how treatment is progressing. It's really good at catching early on patients who are thinking of dropping out and helping the provider to sort of steer the ship in a different direction so that it better fits the patient needs. And I think that's a great illustration of how that regular use of screening and assessment can help so much with retaining patients in treatment and improving treatment progress. So where do we start with all of that? I think a couple definitions are important. An episode of care helps us to conceptualize what's contained within all of the clinical services associated with a set of symptoms. And that begins when the patient presents to treatment and ends at full symptom remission. So the recommended episodes are from 1 month to 4 weeks in duration, and that at that point you're just reassessing and figuring out, is this person ready to move to the next stage, or is this a time to return to the treatment plan and see what we need to update or adjust? So it's not saying that that's where treatment is going to end. Just means you're reassessing and that you're returning to the treatment plan to update it. In terms of the continuum of care, that's thinking about all of the services in varying levels of intensity that you might be able to match a patient to based on their symptoms and their treatment goals. So that could be everything from reintegration into the community all the way up to medically monitored inpatient. So when we look at conceptualizing who needs to be matched to what level of care, if you look across the top here, this is based on scores from the audit, which is for alcohol, or the DAST, which is for substance use. Those are screeners we'll look at more in a bit. And when we look at how people score on this and how that matches to a continuum, reassuringly, the base of the pyramid, so about 3/4 of people are in the low risk or the abstinence interval. And in that case, all you do is say, keep doing what you're doing. You provide that positive health message. Then people who score higher, there's a little under 10% who are in that risky category. That's where you're going to introduce a brief intervention. We'll talk about what that looks like in a moment. And then the roughly 8% who are in the harmful category, that's where it's not just emerging symptoms of drinking. That's, it's already sort of on the cusp of meeting criteria. That's where you want to refer to brief treatment to catch it, head them off at the pass. And then the tip of the pyramid, about 5% actually qualify as what we used to call dependent. And that's where you want to make sure you refer them directly to specialty treatment so that they can get the help they need as quickly as possible. So in terms of the criteria that we can use to match where people are at with the treatment that will work best, the American Society of Addiction Medicine has put forth a really, really beautiful, very user-friendly set of criteria. It is compliant with DSM-5. It does great with keeping up with emerging research, and also, fortunately, it has different breakout sessions for populations that tend to show up a lot within substance use disorders. New Mexico is just one of many states who use ASAM criteria, but that is what we're expected to use here. And as sort of a big picture of what the decision flow looks like with the ASAM criteria, you start, of course, with screening, as we're talking about. That helps us to get a picture of the likely diagnosis and the severity. Importantly, we then look at readiness and relapse potential before we move to patient placement, because even the best treatment, if it's not scaled to where the patient is at in terms of their willingness to engage in treatment or their vulnerability to relapse, it's just not going to be able to help them nearly as much as it could if it's well matched. So the 6 dimensions of the patient placement run from, of course, intoxication and withdrawal, so the immediate presentation, biomedical considerations, so any kind of comorbid or even seemingly unrelated medical concerns. Their emotional and behavioral context, so that includes, what is their personality, what is their level of skill with emotion regulation and similar skills. 4, in terms of treatment acceptance or resistance, that goes back again to readiness for treatment, because that's going to inform where we can best engage them with placement. 5, relapse potential is both going to be about the severity of their symptoms and very much about their psychosocial context. So that goes to number 6, recovery environment, because, for example, if we release somebody from inpatient who did really well there into a home where there's a lot of people who are still using, we're really setting them up for that revolving door, kind of heading right back into treatment. So the decision rules from there, again, run along that continuum of care from outpatient to medically managed intensive inpatient. And I do want to note, as we're conceptualizing that continuum of care, that this is sort of the ideal conceptualization for teaching purposes, but it is important, and I know we talk about this a lot in this echo, to recognize that in a state like New Mexico, where services are chronically overextended and it's really difficult to access, what we need for our patients, we're going to do the best that we can with what we have. And we're going to use these criteria in order to figure out what is the best match possible within what's available. Because I'm sure we've all had the experience of knowing exactly what the right treatment is, but there's no beds available, or there's no, qualified providers available, et cetera. So I do want to show a couple of studies that I think do a good job of illustrating that importance of matching the level of symptoms and the patient's readiness to the type of treatment. You can see here the red bars are the non-matched condition and the tan bars are the matched condition. And I think the one in the middle there, which is the cocaine condition, shows the kind of most dramatic difference in terms of no-shows to treatment. So whether they're undermatched, and it's also true of overmatching, this one is about undermatching, the no-show rate is considerably worse across conditions. So it's interesting that, sometimes people think that patients want to do as little as they have to with treatment, but even when they're given treatment that's really not necessarily asking them too much, they can recognize that it's not helpful for them, and they're not going to spend their time on that. Similarly, I think the middle one here is the best illustration about retention in terms of matching to treatment. So if you look at, this is the addiction severity index subscales. So in this case, a higher score is a better one. You can see that the match actually produced 3 times better outcome at follow-up, which is really quite impressive in this field. Similarly, if you look at the patients ready for step down, those in the matched condition, there's quite a lot more who are ready for step down at follow-up versus baseline. So some of the conclusions for ASAM, sort of from a psychometric perspective, very valid, very reliable, importantly easy to use. And then to the last few slides, valid for both undermatching and overmatching, which as we now know, is a very important consideration for treatment success. It also works really well across populations and for multiple outcomes. So we're going to pivot now to the SBIRT model, which is one of the most well-known and most popular screening and brief intervention models. That's what SBIRT stands for: screening, brief intervention, and referral to treatment. On the screening side, we're just looking for risky substance use behaviors. It is a standardized instrument. Importantly, SBIRT has been developed to be used in any kind of healthcare setting. It requires really only a modicum of training, and training is easily available. The brief intervention component, and we'll go into this more in a moment, is really just about engaging the patient who shows up on the screener as having some concerning behaviors in a brief conversation where you as the provider give a little bit of feedback for context on how their current use fits into the general population, and then as warranted, referral to treatment based on the appropriate level of treatment indicated by the screening tool or the ASAM criteria. So in terms of how brief intervention is performed, there's really a few different ways to go about it. There is some flexibility. You start out by just providing information and feedback about the results. So that could look like, you have this many drinks a day in comparison to the general population, that's significantly more. You then really, really want to elicit the patient's view of their use, and as appropriate, coach them to change perceptions about their use in the context of how those results fit. You really want to encourage them to discuss any kind of pros and cons that they associate. So this particular part is similar to motivational interviewing. You want to get that conversation going so you get a full picture of why they're using and what reasons they might have to change. And then where it really departs from motivational interviewing is that you are giving direct advice, respectfully but clearly. You say, as your provider, I would suggest, based on what you've shared, that you decrease your use. Then, when possible, you're teaching behavior change skills. That could include harm reduction. It could also include relapse prevention, anything that's going to help them reduce their substance use and the potential of negative consequences. And then, really importantly, and a lot of people miss this last step, is you want to make sure you establish a way to follow up with the patient. It could be done in another visit or by phone, but the follow-up is important. You don't want this to be a standalone intervention. There's a lot of great YouTube videos about SBIRT, and I've listed, or Dr. Lindsay has listed here, an app, the SBIRT app, that you can get through iTunes. So again, just a larger graphic representation of that decision flow, and really wanting to emphasize that it's a real quick and easy model, and that the screening is the first and the most important part, because that allows us to unfold into the next few stages as necessary. So looking more generally at screening models, how do we apply ASAM and SBIRT models through these instruments? Just big picture, I want to reiterate that the purpose of screening is really about being able to identify people early on when they either have emerging or existing unhealthy or problematic substance use. We want to be able to detect the entire spectrum. So even people who are just sort of like in the iffy zone, that's a great place to intervene, because then we can catch it before it starts to build up, all the way up to people who maybe have very severe substance use disorders but have not been identified in other contexts, perhaps because they rarely present for treatment. And then again, always want to reiterate, screening is so helpful for making sure that we're finding the appropriate match to treatment where available. So what's the difference between screening and assessment? The big takeaway really is that screening is designed to be sort of quick and dirty, so to speak. The screeners usually are meant to not require too much training to administer or interpret, because we really want to make them as user-friendly as possible, so that we can just sort of filter out people who we don't need to worry about referring to other treatment, and then also figure out sort of what path we can send along people on who do qualify, who do meet those criteria. They're meant to be used across a variety of settings, and also to help the screener figure out where is the next place that I should send this person to make sure they get the treatment they need. By contrast, assessment is much more involved. You really delve into the details. You're trying to get a really multidimensional picture of the patient and their history as it relates to their use, in order to be able to conceptualize the presenting problem and develop a treatment plan that's really patient-directed and responsive to their individual needs. So you're assessing both the substance use disorder and any kind of co-occurring mental health considerations. As we know, with the substance use disorder population, it's very common that there are comorbid concerns, and we want to either establish or rule out co-occurring disorders, and of course, as mentioned before, determine where they're at in terms of readiness for change. A piece that people often forget is identifying both vulnerabilities and strengths, because that's going to help us design the treatment plan in a way that works from their strengths and accounts for their vulnerabilities. So in terms of common screening instruments across the population, the CAGE questionnaire is for alcohol, the CRAFT is general for adolescents, the audit is for alcohol, the DOST is for substance use. NM assist does not stand for New Mexican assist, as people often think. It's NIDA modified assist, and that's general. Then there's the clinical opiate withdrawal scale and the clinical institute withdrawal from alcohol. And lastly, we often don't think of urine drug analysis as a screening instrument, but in fact, it is helpful with identifying initial problems as well as tracking progress over time. So the CAGE, it's a little bit old school, but it can still be useful because it's kind of a big picture instrument. It's just 4 questions. We'll look at them a moment. More than 2 suggests a lifetime diagnosis of substance use disorder. So it's one that kind of points you to a more refined screener or to an assessment process. So the questions here are, have you ever felt you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? Or have you ever had a drink first thing in the morning, aka an eye opener? So you can see how, even though these are fairly qualitative questions, they kind of give that nice big picture portrait that allows you to decide, do you want to proceed with more detailed questions? So the audit was developed for exactly that purpose. It was developed by the World Health Organization to try to get a clear picture proceeding from the CAGE. There's a brief version with just 3 questions, and then a full version is 10. So both are quite quick. And they help us to determine not just if somebody is already at a high risk, but if maybe their drinking has been increasing, or if there are indicators that it might be. So those brief versions are just the first 3 questions. They're very quantitative. It's how often have you been drinking? How many units of alcohol do you drink on a typical day? And then how often have you had 6 or more as a female, or 8 or more as a male? So you can see that's really, that's very numbers based, and that helps you decide, is this something we need to pursue for this person? The drug abuse screening test is set up similarly. It comes in a 10 and 20 item version for adults and adolescents. Very nicely, it aligns with ASAM criteria. And you can see here that there's a mix both of those kind of quantitative and qualitative answers, in the sense that it's asking both about objective measures, so how often people are using and what combinations, as well as how they feel about it. So the NIDA modified assist, I know that's the favorite of a lot of clinicians. It's computer adaptive, which is great. So it kind of leads you through the different decision trees as you input the answer. And it actually evaluates 10 different substance classes with 8 questions. So it's quite brief in that sense. It too aligns with ASAM criteria, and very helpful. It provides links directly to resources for that SBIRT model. So you don't have to know everything off the top of your head. It's going to kind of lead you through it. What's also great about it is you can complete it together with a patient, or you can have them complete it by themselves, for example, when they're waiting for intake, which is a nice way to increase efficiency. The link for that is included here in the slide. For cows and SIWA, I imagine most of the providers here are familiar with these, and this is not just for monitoring during that acute, the potential induction phase, but also it can be helpful, at least during the beginning of medication use, to monitor and to reflect back to the patient how their symptoms are changing, particularly with medication-assisted treatment. And then again, the UDA, I want to emphasize, it's not one we usually think of as a screener, but it can be used in that same context. And it can be really nice for patients when you have an EHM that allows you to plot these in terms of a progress line, because it's nice for them to see that kind of tangible outcome from treatment. In terms of the mental health screening instrument, the World Health Organization's quality of life brief gives us a kind of big picture of how the patient perceives their own life to be going. The patient stress questionnaire is a great compendium of all of the kind of main players with mental health. So PHQ-9 for depression, GAD-7 for anxiety, PC-PTSD for history of trauma, the HUDOS for the disability assessment scale, and then again, the quality of life. And the link for that is here as well. So we'll go very briefly over assessments. The components of a comprehensive assessment, again, are going to be that multidimensional biopsychosocial profile. It's going to be everything from the level of sort of sociological characteristics like demographics, all the way down to ideally a collateral interview or several with family or loved ones, because that's absolutely one of the best ways to improve a treatment plan. Some of the most common assessments that we'll use in this field are the Addiction Severity Index. That's actually a semi-structured interview. The brief symptom inventory, so that helps identify psychological distress, as well as we talked about, the possibility of comorbid psychiatric disorders. The opioid treatment index is helpful because that has a forensic component or a high risk behavior component as well. Timeline follow back, really helpful with researchers, but for those facilities who have the resources to be able to use this, it gives a really great, pretty comprehensive picture of longitudinal use. Form 90 is very focused on substance use disorder history and severity. And then lastly, GAINS is a really great one for a sort of global mental health assessment that actually divides it with indices for internalizing and externalizing problems. Again, very helpful for treatment planning.